find it. Oh, do we know the effectiveness of stool tests such as FIT or GFOBT tests as a yearly? I think they want to know the effectiveness of that for some of the STIs that you mentioned.
I'm sorry, I didn't, Meredith, you're like a little bit quiet. You're saying FOBT?
Yeah, and FIT. It says FIT?
Oh yeah, a FIT test. Well, so that's really a screening test for colon cancer, and that is not, you know, if you had a lot of inflammation in the rectum, maybe it would show up as positive, but that would not be a great way to screen for STIs. Many people are getting FIT tests, and in fact, some health systems are actually just mailing out FIT tests to their patients, so they don't have to come in. But if you are having sex and you're having anal sex, then you would definitely want to come in and get a separate set of swabs for gonorrhea and chlamydia.
Okay, actually, I'm sorry, this is the one final question. Someone wants to know, is HPV transmittable through oral anal sex?
So we don't know exactly, but we certainly know that HPV can be found in the throat. And it's hard to tease apart because HPV can also be found under the fingernails. And so I would just think about HPV as glitter, and it is everywhere in the genital anal tract. As we mentioned, you don't have to have any kind of anal penetration, and it certainly is in the oropharynx. So it's in the mouth and in the throat. So my wager would be yes. I've seen lots of studies about sexual transmission, genital to genital, as well as hand to genital, and I haven't seen so much about like mouth to anus or studies of rimming, for example.
Got it. Well, thank you so much.
But I would say yes.
Dr. Park, it's been great to hear from you. I think that, you know, we all learned a lot, especially, you know, given the notion that older adults living with HIV don't need any sort of sex education. They're not sexually active. So thank you so much. And I'm going to pass it on to Dr. Richard Havlick, who will be moderating our final panel of the day of 3 geriatricians who are in right now.
My name is Dr. Richard Havlick, and I'll be taking over from Dr. Karpiak as moderator for this last session entitled "The Geriatricians Are In." I don't know if you can see me, but I assume you can hear me.
Yes, you're fine.
The first thing I wanted to say is that optimal management of the health of older people aging is really the domain of geriatricians. However, as we're beginning to find out, importantly, as older adults living with HIV are developing higher rates of the same illness associated with aging, many recognize that embracing the geriatric care principles will really help provide what's necessary for the best care possible for such patients. So along those lines, we are in good hands. We're very pleased today to have with us 3 of the leading clinicians and researchers in genetic care and HIV. The format for this session is different in that we will use a panel configuration with all the presentations first. Each person will speak about 15 minutes on various aspects of the topic, and then at the end we'll have a Q&A directed at one or all of the speakers. As you can see up right now, I want to introduce Dr. Meredith Green a little more formally. She's an assistant professor in the Department of Medicine, Division of Geriatrics at the University of California, San Francisco. Dr. Green is interested in the intersection of HIV and geriatric medicine and understanding how to improve care for older adults living with HIV infection. She is also the Associate Director of the Geriatric HIV Consultation Clinic at San Francisco General Hospital, and this is for persons living with HIV, and it's part of something that you'll hear about, the Golden Compass program. So Dr. Green, I'm going to turn it over to you to answer questions about what a geriatrician is and what they do. So I think we're ready for your slides, Meredith.
Great. Thanks for that introduction, Dick. So you can go to the next slide. So I'm going to start off our session by taking a step back and actually talking about what is geriatrics, what do geriatricians do, and even taking a step further back from that just to talk about what is a normal part of aging and what is not normal, because this is something that comes up a lot in my visits. And then I want to talk about if you were to see a geriatrician, or if you can't see a geriatrician but you had an aging focused visit, what that might look like. Next slide. So geriatrics is really the term for the clinical care of older adults. It's the same as saying geriatric medicine. Often it's used, clinics will see people 65 and older, but really the principles of geriatrics can be for any age. And then sometimes you hear, well, what is geriatrics? What's a gerontologist? So gerontology is often defined as the study of aging across the lifespan. So sort of the research or study component. And I think just to point out, as we think about the history of the HIV/AIDS epidemic in this country, I think it's important to recognize that geriatric medicine, while it has been a specialty for a while, was only a board certified, recognized specialty since the late 80s. Next slide. So what is unique, or what might be different about the geriatrics perspective, say from when you go to your primary care doctor? So the first is that there's this emphasis on function. And what I mean by that is many people, older adults, and certainly people living with HIV, are not just dealing with one condition, but multiple different chronic illnesses. And we look at how those illnesses might interact to affect someone's social, emotional, and physical functioning. And then the other piece that's important is if somebody is having some struggles in one of those areas, that you can look at how the environment might support that person's function. A key part of our training as geriatricians is that we work across different settings. So medical care is often thought about as just like the clinic or the hospital, but the reality is that's not where people are. And so the photo is actually from my time as a house calls physician, where I saw people in their homes who had trouble coming into the clinic. And part of my training also involved working in skilled nursing facilities or nursing homes. I would see patients in assisted living and board and care. So knowing what those settings are like and the types of care they can provide. And really, when you're dealing with multimorbidity, which you'll hear more about, or multiple chronic conditions, it's helping to prioritize what is most important to the person that I'm seeing and how can I align their care to meet their specific goals. Next slide. So that's a little bit about geriatrics, but I think what really we have to talk about is this elephant in the room, and this is ageism. And you can see the photo, the woman has a stamp on her forehead that says best before March 1973. And I think we really have to talk about the invisibility that many people feel as they get older because of the society views as a large in this country. And I think unfortunately that also trickles into healthcare. And so I think it's something important to acknowledge and talk about. Next slide. And why is this important? So there have actually been studies that show, just like many other forms of discrimination, that people who feel that they've experienced ageism, it affects their quality of life and their overall health. But it's also your own perspective about aging. So people who have a negative view of growing older, which is often the view that we're told or that we hear reflected in society, actually have higher levels of cortisol or stress hormone release. So your own internal view about aging can also influence your health. And while I think oftentimes it can feel really frustrating to think about how we can change society's views about aging and society's views about race and many other issues right now, I think there are ways you can change your own views about aging that could then in turn help your health. So not buying into this idea that aging is all negative and doom and gloom. Next slide. So I think it's also really important to talk about, well, what is a normal part of getting older and what is not? And so normal changes that occur in everyone as they get older is that there are changes in the immune system that do affect your ability to fight infections. This is sometimes called immunosenescence. The normal changes with age are that arteries and blood vessels become stiffer. There are changes in bone density, or bone mass, as well as it's normal to have more fat tissue and less lean muscle mass with age. And this happens in everyone. I highlight these in particular because these are sometimes concerns about how HIV also influences these things, or HIV treatment, if you think of bone density. And this is why there's been a lot of discussion about biological mechanisms of aging and how HIV might actually inform those. Next slide. So what is not normal? And this is really important because I feel like oftentimes people tell me they have never shared a specific concern with a healthcare provider because they just thought it was a normal part of getting older and there was nothing that could be done about it. And this is especially true for things like urinary incontinence or fecal incontinence. But falls are also not a normal part of aging. Depression is not a normal part of aging. Isolation is not a normal part of growing older, and neither is dementia. And I think while things like falls or incontinence might be more common with age, that does not mean it is a normal part of aging. The other one I would add to this list is pain. So don't let someone tell you your pain is just because you're older. Next slide. So I talked a little bit about what geriatrics is and what is normal aging and what are things that are not a part of normal aging. But what do geriatricians do? And if you saw a geriatrician or you had an aging focused visit in your HIV clinic, what might that look like? Next slide. So I point this out because I think it's important just to also acknowledge the challenges that many older adults living with HIV may be facing. And this includes multimorbidity or multiple chronic conditions, which Dr. Applebaum's going to talk about more, multiple medications or polypharmacy, mental health challenges and concerns, cognitive concerns, and then especially for long-term survivors, I think of some of the unique economic challenges many of the older adults I see are facing because they were not expecting to be here at older ages or plan for retirement, and some of the social challenges that can exist. And I put HIV in the middle of this figure because while HIV, you might have an undetectable viral load and it might not feel like the most pressing concern, it certainly is influencing all of these other parts of people's lives. Next slide. So part of what we do is to break down all of these different challenges and complexities is to think of the comprehensive geriatric assessment. And Dr. Siegler is going to talk some more about geriatric syndromes and specific assessments, but this is an overview. So that function, that focus on function is here again in the middle. And you can see at the top of this figure that medical is really only one part of the piece here. So it's not just medical issues, but it's mental health issues, cognitive concerns, social support or social isolation, economic challenges, and how all of these things interact in the person's environment to support their day-to-day lives. Next slide. And what do I mean by functional status? So there's a lot of ways of looking at this, but this is often what might be asked. And this includes activities of daily living. So things like, Are you starting to have trouble getting out of a chair? Or do you have trouble holding onto things in your hands, maybe because of neuropathy? IADLs, or instrumental activities of daily living, include things like managing medications, managing bills, cleaning, managing public transportation. And sometimes people might be starting to have trouble with one or more of these things for various reasons. And that's when then we can ask for maybe in-home support services or other services to help support that person stay in their current home. Next slide. So this is just to show one example of what it might look like if you were to undergo some of those geriatric assessments. And this is a flow of what happens when people come to see me in clinic. So our medical assistant or our nurse will ask and do several different assessments, including a cognitive assessment, depression, and ask about falls. And then our pharmacist will meet with the person and review all the medications, discuss any concerns or potential side effects, and share those with me. We'll review all the information, and then I'll address any other concerns and finish out some of those other assessments to get really a holistic picture of the person's health. And some of the most common reasons for why people come to see me are concerns about cognition or memory or about falls. Next slide. And I think another way of thinking through what happens in geriatrics or in an aging visit is this concept of the M's. And this includes sometimes the 4 M's, which are what matters most, so that aligning the goals to what's most important to the person. Mind, so focusing on mental health and cognition. Mobility, focusing on how well people are getting around and function. Medications, which is really important. And then this, sometimes you'll hear of the 5 M's, or multi-complexity, multi-morbidity, which you'll hear more about, and I think is very relevant to people living with HIV who are facing multiple chronic conditions. And then modifiable was the 6th M that was discussed last month at the Ryan White conference, as just a reminder that many of these things you can still address, and there are rooms to improve. And I think you'll hear from Dr. Siegler some more about specific mobility and other assessments, but this is sometimes an easier way to remember what are the core principles of geriatrics. And something that we're actually doing to teach other providers, because we know that not everyone may be able to see a geriatrician. I know that the clinic I work in and that Dr. Siegler works in are very unique, and that we're both geriatricians sitting in an HIV clinic. But there are ways of incorporating the 4 M's into other primary care settings or where you get your HIV care. Next slide. So with that, I just want to say thank you. I know we're going to go to our other 2 speakers and then come back for a panel at the end. But thank you for your attention.
Thank you very much. We are going to move now to have I'd like to introduce Dr. Eugenia Siegler. She is the Mason Adams Professor of Geriatric Medicine and Professor of Clinical Medicine, Division of Geriatrics and Palliative Care at Weill Cornell Medical College. I will add that she shares her knowledge by serving on the Medical Care Criteria Committee of the New York State AIDS Institute Clinical Guidelines Program. She's going to discuss how geriatric assessment works and then give you an example of an outcome. Dr. Siegler.
Thank you. Can we advance the slides? These are my disclosures. Continue. So we've had an opportunity to hear from both Dr. Fauci and Dr. Brennan-Ing about COVID, and I think often we sort of view that as dominating the conversation. And one of the things that I want to emphasize is that it is still very, very important to be talking about HIV and aging now for a number of reasons. One, as you've heard today, I think everyone's more aware of the consequences of social isolation and loneliness, and this is an opportunity to continue to educate your providers about this. Practices have been disrupted. We did not see any patients in the office for many months, and we are only starting to bring them back into the office. And this may not hold true for the practice you go to, but practices have been disrupted, and this is an opportunity for you to ask, how are you changing things, and how are you going to take into account people who are aging with HIV? The other point is that it's done damage to budgets. And if we don't talk about aging and HIV, we may lose money that's been allocated and lose opportunities to talk about aging and HIV. So we have to keep pressing on this, and we have to continue to talk about it even as a second epidemic is happening. Next slide, please. So the field of HIV and aging is evolving. It first started as a demographic issue, and since has evolved to understand what those comorbidities and multimorbidities are. What I'm going to talk a little bit about today are aging-related syndromes, or geriatric syndromes, which are common and which are sometimes, though, very complicated to think about and take care of. Next slide, please. So aging-related syndromes are not discrete like diseases, like the comorbidities you'll be hearing about in a minute. They are clinical conditions that don't fit into discrete categories, and Dr. Green mentioned a few of them. Incontinence is one, dizziness is another, frailty you may have heard of, and it's hard to pin down exactly what frailty is, but it is a common phenomenon that we see in older people. It is something that we want to screen for. It has implications in terms of mortality and risk for other diseases, but it's very, very hard to say exactly what it is, as is classic for geriatric syndromes. One of the things that I wanted to go into in more detail today were falls, which also are a geriatric syndrome. Next slide. So I want to spend a little more time, and if you can look at the slide with me, to show you one way of viewing geriatric syndromes. And this is from the World Health Organization, the ICOPE program. ICOPE standing for Integrated Care of Older People. One of the points that Dr. Green emphasized was that we can't view aging as a negative thing. And one of the things about ICOPE that follows up on that is that it views us, it views our bodies as having an intrinsic capacity. So let's view it from the positive approach. What are our capacities? What are the things that we're capable of doing? And on the left, you see different kinds of intrinsic capacity, the ability to move around, vitality, vision, so on and so forth. On the right is a graph that explains that our capacity to do things involves both what our bodies can do and what the environment allows us to do. So the salmon-colored graphic describes what our bodies can do, what is known as intrinsic capacity. The blue describes what our total functional ability is, which is the combination of what we can do and what our environment allows us to do. So that when we are healthy, in the excuse me, the left-hand column, we don't need much help from our environment to maximize our capacity. And our health services are designed to prevent chronic illness and to prevent a diminution in function. When we have illness or other problems that result in a decline in our intrinsic capacity, health services are necessary to try to reverse or slow that decline. But the environment begins to take a larger and larger role to remove the barriers that allow us to function. So that a clinical program can assess all of these things. It can do a screen to assess what an individual's capacity is, but then it responds to that screen in trying to mobilize both health services and environment to maximize their capacity. Next slide. Now, one of the things you may be thinking about is, well, how does all this happen? I'm in a clinic, the clinic is busy, or doesn't have much in the way of resources. They have to do my primary care, they have to take care of my HIV, now COVID's here, and they're spending a lot of money on PPE. How are they going to pay attention to my aging concerns? And once they have assessed those things, how are they going to make all these connections between HIV social services, geriatric social services, and the subspecialists I may need? Next slide. Some of this has to do with what you want and how you can interest the people in your clinic in mobilizing to provide these geriatric assessments. Some of it has to do with what resources are available and how you can encourage people to look at local resources. But it begins often with your telling your clinic what your aging concerns are. Next slide. So let's give an example of a geriatric syndrome involving mobility. Next slide. So this is again still from the ICOPE handbook, and I want to take you through it just so that you can understand how we think about these, but also to give you some ideas about how you might encourage your clinic to do a screen, one of the kinds of geriatric assessment. So the geriatric syndrome is falling, but the intrinsic capacity is locomotor capacity, is the ability to move. So how you help people with improve their mobility begins with screening to see if there is a problem with mobility. And that's at the top with that simple screen. And let's go to the next slide. The screen is as simple as it can be. Now, I don't want anyone to try it here at home without somebody there with you, but it is as simple as rising from a chair. The most basic test of a risk for falling, of a difficulty in locomotion, is being able to rise from a chair 5 times without using your arms in 15 seconds. That's all a screen has to be. It doesn't have to be fancy, but it does have to be implemented in the clinic. It does have to be done correctly and safely. Next slide. There are other kinds of screens for fall risk, for gait. Here's another one that is commonly used. And this is the timed up and go test. Down in the lower right-hand corner is something called STEADY, which is the CDC's program for reducing fall risk. So there are many, many programs that any clinical environment can access to begin to look at ways to improve people's locomotion and to reduce their risk of falls. And these are 2. Next slide. So now what? What happens when someone screens in? What happens when you convince your clinic to start doing fall screening? Well, this is where, again, the ICOPE philosophy comes in, and it builds, again, on what Dr. Green was saying, which is that in geriatrics, we look at everything we possibly can to help someone get better. So if someone screens in as having a fall risk, down on the bottom of the slide, the first part of assessment and management is looking at all of the components of the fall syndrome, of the risk for falling. What else is happening? Again, are there too many medications? Are there medications that increase the risk for falling? Does someone have problems with their joints or with a neuropathy that is increasing the risk for falling? And are there ways that we can manage that? Do they need strengthening? Are they in pain? What happens next? How do you improve the risk for falling beyond the referral to physical therapy? You look at the medical components that may be contributing, but that's not all in addition. The rest is looking at the social and physical environment, geriatric syndromes, and the approach to people who have less of an intrinsic capacity is to see how the environment can help them. So home assessment to make the home safer, providing assistive devices, providing opportunities for people to walk in their community in a safer way. All of these things, managing the social environment, the physical environment, and the medical conditions are ways that we approach geriatric syndromes and are things that can help people live to the highest capacity available. Next slide. So going back to the original slide of the ICOPE approach, I just looked at the locomotor capacity, but you can view the domains of living is in examining these other capacities, strength, emotional health, cognitive health, hearing and vision, which are often neglected. And you can ask your clinic to approach any one of these things and begin the same kind of screen and the same kind of assessment and interventions that can help people function to the best of their abilities. Next slide. I want to finish by encouraging you to think about what you can demand of the clinical programs that you're working with. If the program has been closed or significantly reduced because of COVID concerns, one of the questions you can ask is, when are you open for business in a way approaching normal, and what changes are going to be in place to help us, to keep us safe, to make sure that we can take advantage of the medical care, but also to find ways to socialize and communicate again. How is telehealth going to be used to my advantage? I don't want to never see and be examined by my doctor or my nurse practitioner again. How are we going to combine these things? How are you going to meet psychosocial needs? What kinds of aging assessments can you do? And once you've done an assessment, how are you going to translate that assessment into action? The Golden Compass is an amazing program, but most places can't begin doing a complete geriatric assessment. If you can convince your clinic to start with something, that something still has to be translated into action. And you can be part of the development of those programs. And finally, what community-based services are right for me, and what community-based services are available in this time of COVID, and how can we develop ways to safely provide those services? So with that, I'm going to finish and move on to Dr. Applebaum.
You are correct that we are going on finally to hear Dr. Jonathan Applebaum. He's an HIV treating physician as well as being board certified in geriatrics. He currently holds the title of Laurie L. Dozier Jr., MD, Education Director and Professor of Internal Medicine at Florida State University College of Medicine, where he also serves as chair of the Department of Clinical Sciences. His interests focus on LGBT health disparities and aging and HIV. He's going to take a broad look at the multiple conditions that affect older persons living with HIV. Dr. Applebaum.
Thanks, everyone. And yeah, I'm going to talk a little bit more about some of the issues that we heard from the two previous speakers. I'll take the next slide. So I'm going to first spend a little time talking about something that you've heard about from the two other speakers about multimorbidity, talk about some of the components, how we treat it, and then I'm going to spend some time talking about maybe some tools for you as patients that you can use when you go to see your provider. I think patients who are equipped with information and questions, I think will make the visit that we all know is somewhat limited these days in time, make it much more efficient. So I'll take the next slide. So what is multimorbidity? And we've heard this term from the other two speakers. A lot of different definitions, but think of it as the interaction of several diseases and or syndromes, because we talked about that geriatrics, may the conditions that older people have can be divided into certain diseases, or there may be these syndromes that are more difficult to define. And the effect of the older person is really more than the sum of each of these diseases. One of my colleagues used to describe multimorbidity as saying is that the whole is more than the sum of the parts. Basically, if you focus on one disease and a patient has several other diseases, how you approach that disease, how you treat that disease will undoubtedly affect the other conditions. And it may affect it in a positive way, or it may affect it in a negative way. And just realizing that this will have an effect on the things that Dr. Green talked about, like function. Next slide. So I've listed some of the common health issues that older adults may have. Things like high blood pressure, diabetes, high cholesterol. They may have heart disease, and it could be, I'll go back to slide, yeah. They may have heart disease, it may be coronary disease, it may be heart failure, possibly maybe both. Patients may have lung disease, they may have asthma or obstructive lung disease. Patients may have a decrease in the function of their kidneys. That tends to be a common condition as we age. They may have cancer. Many older patients have arthritis. We talked a little bit about cognitive impairment. That may be an issue. Liver disease. The liver is an important organ to metabolize medications and to detoxify toxins. And then there's this syndrome, and then I've listed three syndromes, frailty, falls, and polypharmacy. We heard a little bit about falls. Dr. Green talked a little bit about polypharmacy. Basically, polypharmacy is taking more than a certain number of drugs. Usually in geriatrics, we talk about anyone who takes 5 or more prescription medications, that constitutes polypharmacy. The problem with polypharmacy is the more drugs you take, the more likely that the drugs will interact with each other and or with the diseases that you're treating. And then the concept of frailty, again, I agree with Dr. Siegel that the definition is very hard to come up with. It's a very difficult condition to actually diagnose in a primary care office. But we can often have a sense of it if a person has been losing weight, if they have decreased muscle mass, if they complain of fatigue, if they have poor exercise tolerance. Those are some of the things that will contribute to frailty. So we take these conditions that may occur as you age and then add in HIV. You can see where the evaluation and management of these conditions is really a complex issue. Next slide. So I'm going to take some of these conditions and talk a little bit about maybe approaches that you could take when you're going to see your doctor, things you can maybe talk to your clinician about. High blood pressure, very common condition affecting many, many millions of Americans. The issue as geriatricians that we see is that often over-treatment of the blood pressure is actually more harmful than under-treatment of the condition. It contributes to falls. We heard before about falls. overtreating blood pressure is actually not an uncommon condition that can predispose to falls. If patients are having difficulty getting their blood pressure controlled, they're often put on multiple medications. That contributes to polypharmacy, which we just talked about. So if there's any way that you can ask your clinician, is there any way that one or more of your medications can be combined? There are several combination blood pressure medications that can be prescribed that may decrease the number of pills you have to take. Next slide. Diabetes, and I'll just mention that overtreatment of diabetes also can be more dangerous. Older patients are more prone to having a low blood sugar reaction to their diabetes medication. And so we feel that overtreatment of diabetes is actually more harmful than undertreatment. And in fact, the recommendations for targeting the average blood sugar is actually allowed to increase as you get older. But we still want to try to keep your blood sugar as normal as possible. And this is where self-monitoring is so important, and making sure that if you are monitoring your blood sugar, you bring those records in with you to your clinician when you see your clinician. Next slide. Heart disease, also a very common condition, and persons living with HIV are more, go back a slide. Nope, you're wrong way, go back. One more, there you go, thank you. Persons living with HIV have much higher rates of heart disease, and it seems to occur at a younger age than in persons who are not living with HIV. Really, really important to reduce the risk factors, and the #1 risk factor for heart disease is smoking. And there's plenty of good data that smoking itself, in combination with HIV, reduces life expectancy and to a significant degree. So I am always harping on my patients, and particularly my patients who are living with HIV, the dangers of smoking and the need to do everything we can together as a team to have them stop smoking. Other risk factors for heart disease include hypertension, diabetes, and elevated cholesterol, and those all need to be addressed. And it's very important to maintain physical activity. Maintaining physical activity does not mean you have to go out and spend money and join a gym. Any kind of increase in physical activity, walking is probably the best cardiovascular exercise. And as long as you're doing 30 minutes of exercise 5 times a week, that's what's recommended. And if you can do that, that's great. But you also have to be aware that certain HIV medications, in fact, may predispose you to heart disease. Boosted protease inhibitors and perhaps abacavir have been shown to have a higher risk of, in patients who are taking those, have a higher risk of heart disease. And the newer HIV medications, integrase inhibitors, and the nucleoside drugs seem to be much more favorable as far as not causing heart disease. Next slide. Kidney disease. So kidney function normally decreases with age, but having those comorbidities of high blood pressure, diabetes, and even vascular disease can accelerate this. And HIV does play a role, absolutely, in kidney disease. And medications can also contribute to kidney disease. Some of the HIV medications are known to have a negative effect on the kidneys. Tenofovir, which was replaced or has been replaced with the newer version, TAF, both can cause renal disease, although TAF seems to have less of an effect. And the trend seems to be to try and use combinations that in fact may not have either one of these drugs. Also important, particularly I'm down in Florida, it's really important in warmer climates, but for anyone, to maintain hydration. Next slide. The liver, as I mentioned, is important in breaking down medications. It's a major organ to metabolize medications, to begin the process of getting rid of the medications from your body. but it also metabolizes and breaks down any toxins that we may ingest. And so that's an important organ that we want to protect. The comorbidity of hepatitis is a real danger to your liver. So knowing your hepatitis status, particularly whether or not you have hepatitis B or C. If you have hepatitis B, you need to be treated for it. And unfortunately, right now, that means a lifelong treatment. But if you have hepatitis C is curable. And we know that patients do better if they have been cured of hepatitis C. Important to remember that alcohol is a toxin that affects your liver. So trying to minimize alcohol will decrease the, or minimize the amount of alcohol will decrease the effect of any negative effect on your liver. I also I want to mention that obesity causes fat to infiltrate in the liver, something we call fatty liver. And that is now the major cause of chronic liver disease in the United States. As we have begun to cure hepatitis C, fatty liver disease is now becoming the most common cause of liver disease. And important, if you've ever had hepatitis B or hepatitis C, your clinician needs to continue to screen you for the development of liver cancer, which can be a late complication of these viral infections. Next slide. So getting back to protecting your liver, avoiding toxins, so too much alcohol and too much acetaminophen, Tylenol, can cause liver damage. Know your hepatitis status, make sure your clinician knows your hepatitis status, and keep your weight down to try to prevent fatty liver disease. Next slide. And I'm gonna kind of end this section here talking about cancer. Remember, cancer is the second leading cause of death in the United States after heart disease. Heart disease is still #1. There are actually now very few cancers that are caused directly by HIV, but there are several cancers, and I've listed lung cancer, and we talked about anal cancer, that are more common in persons living with HIV. The lung cancer link is clearly related to smoking. Okay, so it gets back to smoking. Smoking affects your heart, and it can affect your lung in the form of cancer and obstructive lung disease. And then make sure you're getting your recommended screenings. So the normal recommended screenings for things like cervical cancer and breast cancer and gastrointestinal cancer are really the same as for the general population. So you do need to talk to your clinician, you know, that even though you are living with HIV, you still need to get screened for other diseases. Next slide. So kind of in summary, the things that you should talk to your clinician about, it's important to work together as a team, but it's important also for you to have some knowledge and bring that knowledge in so that your clinician can participate, and you and your clinician can participate in making decisions. I always have this is a typical geriatric move. We ask our patients to bring all their medications in. We used to call it brown bagging, but you don't have brown bags anymore. So just bring in all your medications in a bag. That includes prescription medications, non-prescription medications, supplements, whatever kind of pill or supplement that you're taking, bring it in so that your clinician knows what you're taking. Also bring any health monitoring. We're all doing things like taking blood pressures at home, or taking blood sugars if you have diabetes. Those are really important to bring in and let your clinician see. If you get your vaccines outside of the clinic, which a lot of my patients do, they'll get their flu shot at CVS. They may get their shingles vaccine there. It's important to bring that information in because we don't always get that. And then it's okay to talk to your clinician about the need to test for and prevent common health issues, particularly the ones I just mentioned. Next slide, I think that's my last one. Yep. So yeah, I guess we can open it up to questions now.
Meredith, have you been keeping track of some of the questions as I have? And maybe between the other Meredith, our Meredith, or is there anybody who can give some questions? I have some.
I have some also.
Why don't you go ahead and Victoria and see if there are any questions that may fit specifically to the individuals, though it seemed like the majority of them were ones that could be answered by anyone or all three of our presenters. So can you find some that are specific maybe for one of the presenters?
Yes, there was a specific question to Dr. Siegler. How do we know when we are declining enough to seek medical advice versus just normal aging? And that was from Mike.
That's an important point because, as Dr. Green has said, there are many things that we've ascribed to normal aging that really aren't. I think the way that you can look at it is that there are always opportunities just to get a consultation or to ask about what healthy aging is and how to preserve one's health. But if there are things that bother you, if you are worried about your memory, if you are not able to do the kinds of exercises you used to do, any of those general syndromes, as we would call them, are justify a consultation. But look at it from both the positive as well as the preventive, as well as the corrective point of view. One of the things that geriatricians can do and encourage others to help people do is counsel about healthy aging. And we would love to get started on that before decline begins.
Victoria, did you have any other specifics? I had a couple of more for Dr. Siegler, but I'd like to see if we can find some for our other two presenters.
None specific. We have quite a number of questions, but none just specific for any one person.
Maybe we should go on then and open this up to all three of our participants for responding to some question, like one that I saw from Eric early on. When do I think about, I'm 58, I'm a long-term survivor. When do I think about seeing a geriatrician? Any of the three of you have an answer? Go ahead, speak up.
Unmute yourselves.
I think we're all looking at each other. I can start and feel free, my colleagues, to join in. So I just want to emphasize it's not like, I don't think there's one right or wrong age cutoff. I think a lot of times with HIV, we use 50 and older. Certainly that's like the age that we use for a lot of our HIV and aging services, but I have seen people in their mid 40s. So it's not a magic number. I think, you know, like Dr. Siegler said, if you're starting to feel there's a concern, you should bring it up with your provider. And then I think helping them to think through who, if you need to see a specialist or something else. It certainly doesn't have to be just 65 and older.
Any other questions? I notice John has got his mute on. There you go. Any additions to that?
You know, I agree with Meredith. I would also say that if you're dealing, if you and your primary care doctor are dealing with multimorbidity, and particularly any of the number of geriatric syndromes, that might be time to get a geriatric opinion. Obviously, we want to try to get people in earlier, but the thing that sort of the elephant in the room is that there's just not enough geriatricians out there. So I think primary care and HIV docs are going to have to take care of some of this. Yeah, I'll just leave it at that.
So Victoria, you've been fielding these questions very well. Can you pick out some others that catch your eye?
Okay, yes. Aaron asked, at what age should we begin those mobility tests?
This would be Dr. Siegler, maybe.
Again, if you want a general number, it would be age 50, but just because that's I think the way most groups are beginning to identify the need to begin to think about aging, but it's useful to focus on health, and if you are not able to get up from the floor the way you used to, or able to do think functionally. You know, are there things that you used to be able to do that you can't do now? That's as good a screen for you to begin to ask your doctor, well, what, or your nurse practitioner, your clinician, where do we go from here? I think all of us are a little hesitant to choose any particular age. We want you to be as functional and capable as you can be, and you're the best judge of whether you aren't doing quite as well as you used to. The key thing is not to let it go on too long, to recognize, okay, let's get to the bottom of this as quickly as possible.
I'm sorry. Go ahead.
I want to open this up to everybody. I know for the older adults that I talk with, they have difficulties in asking their doctors certain questions. And so one of the questions that Rob asked, which I think is important, is where can we get a list of all the recommended screenings, including age to start, and the frequency? Because if you don't know what to ask, you go into the doctor and you get tongue-tied. So what is there a list to tell you what are the screenings at this age you should be doing, how frequent, and how can we get access to that?
I know the CDC has this on the website, and it's you know, very easy to read in layman's terms. I would probably start there. I mean, there's a lot of other resources, but I think I would start at the CDC.
Yeah, I would say CDC, and I think Health in Aging, which is through the American Geriatrics Society, also has very good patient or people-facing information, not just geared towards medical providers.
Dr. Havlick, does the NIA still have age pages?
It's been a while since I've been there, but I would be surprised if they didn't. But that is a good source. Just go to the National Institute on Aging and see what kind of resources they have available. I would believe that there's a good chance that they have something that could be used.
Yeah, the NIA does have still some exercise videos and other things geared towards older adults. Their Go for Life program is a useful resource.
Steve, are there any medications that as one ages one should avoid totally or really look upon with suspicion? Are there like quote unquote no-nos in the realm of pharmacology?
The answer is yes. And the American Geriatric Society publishes a list, and it's updated fairly frequently. It's called the Beers list. And they're not no-no medications. The way they describe it is that potentially inappropriate medications. But yeah, there's classes of drugs that we as geriatricians do not like to prescribe to older patients.
So how often do you encounter possible untoward interactions between medications that a patient might be on already and you want to prescribe another medication and you have to avoid doing that or have them change the one they're on? Is that a frequent occurrence?
Yes. Yes, I would say yes, that's a common thing that comes up, and not just in terms of like formal drug-drug interactions, but I think inadvertently, you know, just because of changes that happen with age, the adverse effect of one might exacerbate another problem. So for like, you might be on one medicine for your blood pressure and one for your prostate, and those can both contribute to dizziness. And the combination might be what tips you over to feeling really dizzy, for example.
Can I ask a polypharmacy question? I read an article a couple years ago about the cumulative effects of too many drugs on depression. And I went through, I was taking about 12 meds, and I went through, and about 6 of them listed depression as a side effect in less than 5% of patients. But if you're taking 6 medicines that all have, you know, a 1 to 5% risk of depression, does that become cumulative? Because I think when I cut some of those meds out, I actually did feel better, and mentally better. So all these drugs, do those side effects all kind of build up to end up with a 30% chance of depression? Or is that just conjecture?
Any responses to that?
It doesn't work that way statistically, but it can work that way just in terms of, as Meredith gave an example, drugs can have synergistic effects. There's another approach. The British have an approach called stop-start, and they ask for an evaluation of each drug and whether it is appropriate and whether its side effects are burdensome. There are times that we don't give drugs to people because of therapeutic nihilism. This person's too old, why bother? So the prescribing wisely is really the goal. And if you were able to stop 6 medications.
No, I didn't stop all 6. I stopped some of them. And
but you were able to stop some medicines. That means that, and you had 6 you were worried about. That means that there was an opportunity when your clinician reviewed your medications with you to go over which ones were really necessary, which ones might be causing side effects. There are some comments in the chat box about pharmacists, and some programs are fortunate enough to have pharmacists review medications, and I think that is just such a wonderful opportunity. If you have a pharmacist in your clinical program, to have them view with a geriatric lens. So it's not just what are the HIV medications, but how are the HIV medications interacting, and does this person have a risk of having a side effect of these medications because of their age. That's just so valuable. The other thing to think about, if you are in a practice which does not have a pharmacist, are you working with a specialty pharmacy? Is your practice working exclusively with a specialty pharmacy whose pharmacist might be willing to spend some time with reviewing the medication lists of older patients? Mark, your comment is sort of frightening to me that you were able to look at your medications and worry about 6 of them. That doesn't mean that you stopped them all, but it meant that you talked with your clinician about, do I really need these? And that kind of opportunity to review all the medicines and determine what do I need, and are these the safest drugs for me is crucial. Meredith, maybe you can comment a little about how the role your pharmacist plays in Golden Compass.
Sure. I mean, I love pharmacists and I love working with them, and I'm very fortunate that our clinic has a pharmacist who's there every day and full time. Not everyone will have that, but I think then there are ways either to, I think one of the things anyone can do is to try to use only one pharmacy, because that makes it easier because you can establish a relationship with the pharmacist in that particular pharmacy. But yeah, so our pharmacist does spend time reviewing medications in detail. So that brown bag idea that Dr. Applebaum brought up of it is really important, I would say, once a year to just go through all the medicines you're taking. And that includes not just prescription, but over the counter and all the vitamins and herbal supplements you're taking too, because those can also interact with prescription medications. And so we actually sometimes end up adding many medications to someone's list once we realize all the things that they're taking at home that aren't necessarily a prescription. So I think don't just assume because you can get something over the counter that it is safe. You should actually really talk to either the pharmacist in the store you're buying it from or your provider about starting any new medication. But in terms of the pharmacist, because of their expertise, they can, look up drug-drug interactions easily. They can also look up and help with identifying if there might be a side effect, and they can also look at those potentially inappropriate medications that Dr. Applebaum and Dr. Siegler both mentioned.
I was shocked to find out that Rolaids interfered with one of my HIV meds and actually could lower the effect. Actually, a couple of HIV meds that can do that. I do want to emphasize as we talk about this that I know clients who stop their meds without talking to their doctor, and that's a big no-no, that we have to make sure that we ask our doctors first, can I stop some of my meds, and not do it on our own. Because I do have clients who do that.
Victoria, we're sort of right at 5 o'clock, but I think we have time to squeeze in a few more. Do you have one that you think is particularly apropos, maybe for all three of our presenters?
One more.
I have.
Go ahead, Dick. You asked the last question.
Let's see what I got here. If I am going to a geriatrician or can see one regularly, will that geriatrician help me to live longer and have a happier life? It's that's my final question for you.
I don't think one would hope so. One would hope so. Anyway, with that, I think it's time to end. We've had a long day. It's 5:05. Thank you, everyone, to our speakers, and especially to everyone who attended. And all this information will be available, the PowerPoints and the recordings, on the National Resource Center for HIV and Aging, www.aginghiv.org. If not by tomorrow, but certainly by next week. Many have asked to be able to re-access these resources. Also, they're going to be posting in the chat room a survey on SurveyMonkey, but if you can fill it out now, we appreciate it. Otherwise, it will be sent out via the script, via the mail system, by emails. Your feedback is really needed. But thank you all for really an amazing day.
Thank you all. Meredith, do you have the evaluation that I sent you that you can put in the chat box there?
I put it in the chat box.
Great. And we'll be emailing it to you again. So please fill out the evaluation. It's so important to us.
Again, thank you. Have a great evening.
Victoria, Meredith, and the staff, and all you've done. And of course, just the amount of work that Dr. Karpiak put into all of this. This was his original idea, and hopefully it has met some of the needs that were not being met in most webinars. That is, for people who are non-professionals but are HIV positive, etc. So again, thanks to everyone, and again, thanks to our presenters.
Yeah, World AIDS Day is coming up
on
December 1st. And if y'all fill this out and indicate that you would like something similar, maybe around then or another point, we can definitely try to make that happen.
Remember, tomorrow is HIV and Aging Awareness Day, right?
Yes.
Yes.
And Rosh Hashanah, the Jewish New Year. So Shana Tova, Happy New Year to folks who are celebrating.
There you go.
All right, I'm gonna end the meeting now.
Bye-bye.